really an honor for me to present today our data. So we talked a lot about what I'm doing, but I'm not going to present that today. I'm really focusing on breast cancer and the data we have of immunotherapy combined with radiotherapy. I hope I can give you the answer. It's a big pressure I have here. Immunotherapy has really changed the prognosis of a lot of cancer patients. And the question is if that's also for breast cancer. So breast cancer used to be like immunogenic cold. So the first studies with immunotherapy as a monotherapy, they were not really convincing. But now there have been some studies with the combination of immunotherapy with PARP inhibitors or with chemotherapy, and they seem to be promising. So this is the new era of immunotherapy in breast cancer. What we have seen before, so in metastatic breast cancer, especially for the for the triple-negative breast cancers, we have the atezolizumab or pembrolizumab, as we just heard, with the PD-L1 high expression in the tumor. And also in the localized situation, we now have the Keynote 522 study that we just saw an overview of. So in that situation, it is also positive. So what we saw with these patients is that they have a better pathological complete response at time of surgery, that they also had a higher event-free survival, and that the toxicity rates were not significantly higher. So that's great, but there are some challenges, and I want to focus on that now. So first of all, we know that with immunotherapy, there is no complete response rate, unfortunately. So this could be where radiotherapy might play a role. Also, we know that patients can develop or not patients, but the tumor can develop an acquired resistance. And so if that happens, that can also be something where radiotherapy could play a role. Then we also know that about 20% of metastatic breast cancer patients are oligometastatic. And we know from a lot of other tumor types, especially for lung cancer, that if you ablate these lesions, these patients benefit. So this might be the case in breast cancer as well. And I will focus on that later. Then about 30 to 50% of breast cancer patients who are metastatic will develop a brain metastasis at some point. And this is also where radiotherapy can play a role. And then last but not least, the abscopal effect. So this is something we always hope for, that if we add the radiotherapy to the immunotherapy, that the anti-tumor immune response will be enhanced and that these patients will benefit. So a lot of reasons why we could combine these. And I have been looking at the data, and for breast cancer, it is a little bit disappointing as well. I will try to show you what we have at the moment, but since we only have approval of immunotherapy for breast cancer since 2019, the data is very new and we don't have a lot of data at the moment. Now, I first want to focus on the localized treatment of radiotherapy, then I will go on oligometastatic disease, and then I will go to the metastatic situation, the polymetastatic situation. So first of all, always what this symposium is also about, if we add our radiotherapy to the immunotherapy, we want it to be safe. So we want to help these patients, we don't want to kill them. So this is a very nice study, I think. It's a SEER database study with over 16,000 patients that was published last year. And what they show is that if you add radiotherapy to immunotherapy in any location in the body, the toxicity rates on average were only 1% higher. So this is very promising. So this looks like we can add it safely. End of question, I can stop my presentation here. The problem is with this study that there were no breast cancer patients included, simply because the immunotherapy is only since 2019, so we don't have this data here. But we can say for radiotherapy, of course, if you treat metastatic lesions, the organs at risk are the same. The metastatic lesions usually behave the same in different tumor types, so we can kind of extrapolate these data to breast cancer as well. So first start with localized triple-negative breast cancer. So we just saw the Keynote 522 study. Now, This study, at first they excluded, or they did not include radiotherapy, but they wrote an amendment and then they included radiotherapy. So these patients received concurrent radiotherapy or pembrolizumab 2 weeks after radiotherapy. And what they showed is that pembrolizumab really benefits for these patients with an event-free survival. The only problem is that both arms received radiotherapy, so we don't really know what the effect of the radiotherapy is. We only know that pembrolizumab is really having a good effect and compared to a placebo. But if we look at the toxicity, well, we already discussed that yesterday as well. So this study, they did not really present the radiotherapy-induced toxicity. So I also looked into the supplements, everything. It's not there, which is very surprising, of course. But there are some toxicities that we can expect that are there after radiotherapy. So I highlighted them there, like nausea, fatigue, rash, skin reactions. And what you can see in this overview is that these data, so these toxicity rates were not higher in both groups. So if you think about that they both had radiotherapy and one group also had pembrolizumab, you might be able to say, okay, this looks like a safe thing. This looks like radiotherapy did not add any additional toxicities when pembrolizumab was added. So this is promising, but we don't really know 100% for sure. So I would give it a green light. So it looks like a localized radiotherapy in the pembrolizumab setting is safe. And for the localized treatment, this is also all we have at the moment. So if I make an overview, I would say the benefit of adding radiotherapy to immunotherapy in early stage triple-negative breast cancer is, well, the data is scarce, but it looks like there is a possible benefit and it is at least safe. Now let's go to the oligometastatic situation. We all know the SABRE-COMET trial, I guess. So this study compared standard of care treatments to standard of care with an ablation of up to 5 metastatic lesions. And they also included breast cancer patients, which I think is very interesting. What they showed is that when you ablate these lesions, these patients really had a benefit in overall survival. And if you see these percentages, 27% to 13%, that's massive. But this was a mixture of several tumor types. And also for the breast cancer patients, these did not receive immunotherapy. So with this study, we can say, yes, it appears that if you treat these lesions, these patients benefit. For breast cancer specifically, with immunotherapy, we don't know. So what other data do we have? So this is green light. This is the Energy BR002 study that was presented at the ASCO last year. And this is one where stereotactic radiotherapy or surgery of up to 5 extracranial mets combined with a standard of care therapy was compared to standard of care therapy alone. And they included about 8% triple negative breast cancer. Most of them were hormone receptor positive. And unfortunately, this study was negative. So they did not see any benefit of ablating the stereotactic lesions, which is kind of surprising if you compare it to lung cancer, for example. Now, this is also the reason why they did not want to continue the study to a phase 3 trial, which I think is very unfortunate. And if you look at the specific sub-analysis, you see that especially patients... This is not very intuitive. Yeah, so especially patients that only had one lesion, where that was ablated, they benefited, and also patients that were hormone receptor negative. So it could be, so this study is negative, I give it a red light, but it could be that ablation of metastatic lesions in the triple negative setting or the hormone receptor negative setting might be beneficial for these patients. But with this study, we don't know, and unfortunately they are not continuing it. Now, the next study is the CURB trial, and that's also a little bit disappointing. So this was presented at the ASTRO last year. And this study also compared ablation of stereotactic ablation of lesions in the oligometastatic setting. And they had one group with lung cancer and the other with breast cancer. And the other arm was standard of care therapy. Well, it's not really clear if this was also immunotherapy, because we only have these slides. but it was standard of care therapy. And also here, lung cancer, as we expect, yes, a massive effect of the ablation, but for the breast cancer, again, no effect at all. So I don't know, this is kind of worrying, because this is what we are doing in the clinical practice now, but I don't know if we're actually doing the right thing here if we ablate these lesions. So a red light as well. So if we add all this data, we can say that in the oligometastatic setting, there appears to be a benefit if you look at the SABRE-COMET trials, but we don't know what the relation is with immunotherapy and in breast cancer. And the other studies were negative. So I would give it an orange light. At least we can say that the stereotactic radiotherapy is safe in this situation. But if we do anything good, we don't know. Now let's continue to the polymetastatic situation. Here we hope for an abscopal effect. And this study is the TONIC trial. This was a metastatic triple-negative breast cancer cohort where patients received nivolumab, and they randomized nivolumab with several additional therapies, and one of them was irradiation of one lesion with 3 × 8 gray, so an ablative dose. They unfortunately did not see any benefit of irradiation in the treatment response if they compared it to the other arms they had. So this is a negative study for us. Then we have this phase 2 trial. This was in 28 patients, so a small study, also metastatic triple negative, and these were heavily pretreated, so up to 7 lines of therapy. And this study had a different approach. So here they treated one of the lesions with an intratumoral injection of virus particles, and they started a valacyclovir gene therapy, and then they ablated this lesion, also only this lesion, with 5 × 6 gray, and then they started pembrolizumab. And this was a good. This showed a good response. So in these patients, you can see if they responded. Some of them lived for over 20 months, which is in this situation very extraordinary, I would say. So this study is positive. Yes, the first one, that's really positive. Yes. And then there was another phase 2 single arms trial. Also in polymetastatic triple negative breast cancer, also heavily pretreated with up to 7 lines of therapy priorly. There was also a radiotherapy of 1 lesion, and then pembrolizumab was started. And also here they saw a higher response rate than what you could think of when you look at immunotherapy alone. Half of their patients did develop severe toxicity, but this was all caused by the immunotherapy and not by the radiotherapy. For once, they also really talked about that it was really not radiotherapy induced. So that's good. So also here a green light, but a very small study. Then the last study I would like to talk about in this setting, this is a phase 1 trial, and here fresolimumab, which is a TGF-beta blocking antibody, was combined with radiotherapy with 3 × 7.5 gray, also in metastatic triple-negative breast cancer. And here they saw a possible survival benefit as well, with an increase of CD8 positive cytotoxic T cells, and it was also safe. So here also positive. So if we combine all of this, we can say in the polymetastatic setting, if you want to go for an abscopal effect or an tumor-enhancing immune response, it looks like in breast cancer we can get this. We have to think about that these studies were very small, phase 2 trials in very heavily pretreated patients, but it appeared to be positive, and maybe the negative result of the TONIC trial, which was the only negative one in this overview, could be due to several factors, like when they started the radiotherapy or what kind of collective they had. So this is what I wanted to say about adding radiotherapy to immunotherapy. So as you have seen, there is not a lot of data, and not everything of it is very promising, unfortunately. But luckily, there are some ongoing trials now, and the first results will be presented already in 2023, so this year. So this is very positive, I would say. And I hope that with these trials, we have a bit more clarity about how to integrate radiotherapy in immunotherapy and breast cancer. So as a conclusion, immunotherapy now plays a role in triple-negative breast cancer treatment. There is not a lot of literature, but it appears to be safe. For oligometastatic breast cancer, the results are kind of inconclusive. At least the radiotherapy is safe there. In polymetastatic disease, it appears that stereotactic radiotherapy can really enhance the immune effects here. And there are some prospective studies on the way. Now, in our consensus statement, what we have is that for early triple-negative breast cancer, the combination is safe. And if you want to, so with normal conventionally fructuated radiotherapy, I have 5 seconds now of you. And for the ultra hyperfractionated regimens, it also appears to be safe. There was also a strong consensus, and this is the end of the presentation. Thank you very much. And thank you to the panel that worked with me together on this topic.